Division of Public Health, and a bit of a description as to what the office is, what it encompasses, and what the mission of that office will be. And second, to give an overview of many of the projects and activities that are going on within the Office of Global Public Health. So Sharon Talboys and I will take a few minutes this evening and talk about the office and what our goals are to help advance global public health and the mission of global public health within the division. So, by brief overview, I'm going to take a little minute and briefly go over the philosophy and our history and how we've come to be where we are today, and a brief explanation of why we've been doing things the way we have been and what that portends for the future and the way that we hope to continue. Second, a description of some of the activities that we've done that are ongoing and that will be going on into the future. And then finally, kind of what our anticipated impact is to continue to have global public health programs here within the division. So to start with, I'd like to just use this picture as the emblem of the philosophy, of our approach, of how this started. In approximately 2004, Dr. Alder made a visit to Ghana. And about that same time, there had been a small child out in one of the communities that had been diagnosed with malaria. One of the communities was a little bit farther from the city and had some difficulty receiving appropriate treatment due to distance. However, when that child finally made it to the hospital, received definitive care for malaria, and was treated, the treating pediatrician realized that at the same time the hospital was starting to have the thought that some of these disease conditions could be prevented if we were to get better involved with community medicine. And the communities at the same time were struggling to achieve their health-related goals and looking for more help from the health system. At the same time, the University of Utah was looking for global health areas in which they could be involved. Dr. Hale had been in Ghana for about 2 years by this time, working with medical students at the Konfanochi Teaching Hospital and at other hospitals in the area. But by this time, it had kind of settled to the Konfanochi Teaching Hospital. Well, that is the hospital where this young child was taken. That's the hospital that wanted to make the outreach into the community. And so this relationship was established. On your left is Dr. Daniel Ansong, pediatrician, head of the Research and Development Office at the Konfanochi Teaching Hospital. In the middle is Nana Tabri, the chief of this area of Barakuma and some of the surrounding communities. And then obviously on the right there, after he let his hair grow out a little bit, Dr. Alder. And it was this relationship between the community, between our university, and between the teaching hospital and the university, KNUST, the Kwame Nkrumah University of Science and Technology, that began the approach of community-engaged participatory research in Ghana. Now, even though it began in Ghana, over the past now 8 years, we've had the opportunity to take the model of community-engaged research, building partnerships and collaborations at the university level, university to university, academic to academic, student to student, involving communities in a number of sites. In India, in Ghana, in Peru, in China, in Armenia. Did I say Uganda? And in Uganda. This is just a list of some of our partners with whom we're working. Now, the approach we've decided to take, that community engagement, there's a key word that overlies and encompasses the mission of the university and the mission of our global public health program and these programs, and it's scholarship. And that scholarship can be broken down into 3 distinct components. And those 3 distinct components, while they're all the same philosophical idea, the actual name has been evolving. And the current evolution identifies them as knowledge production, which is research, which is really coming up with the new ideas, developing a new understanding, new ideas, advancing our scientific knowledge. Our community engaged programs have included community health assessments in all of our partnered communities, gaining more knowledge about how to correctly assess, how to better understand the needs of our communities, the needs of our partners, the needs of our collaborators, to develop appropriate knowledge-producing projects in our areas. We've looked at health systems in nearly all of our areas, in Ghana, in India, in Armenia, in China, and in Peru. We've spent time investigating, discussing, meeting with health officials, hospitals, clinics in all of those areas. There's a list of some of them that you'll get more detail about later. Currently, in Ghana, I just got back Sunday, we've launched a micronutrient malnutrition study sponsored by Kirk Humanitarian. Kirk Humanitarian has been donating micronutrient supplements to a number of areas around the world to improve the maternal childhood outcomes related to perinatal mortality. However, they realized that they have not had appropriate measurements of success. Are they doing it the right way? So we've launched a 4-year study into how do you correctly, how do you distribute and educate for micronutrient distribution to communities where this is a new experience. We've had environmental studies that have looked at water and sanitation, not only evaluation, but have also brought out completed projects. And we'll talk a little bit more about that later as well. And then also issues of gender equity, which many are kind of interwoven throughout a number of these projects. So the second phrase in that what is scholarship is knowledge reproduction. And this is what we know, let me tell you. This is the see one, do one, teach one. This is taking the knowledge that's been gained and teaching others that knowledge. This is the student-involved portion of the global public health projects. And when you look at the student participation and their response, and I'll let you all read it, I don't need to read it to you. We've had graduate students and undergraduates comment on both the skill building and the life-changing experiences they've had by participating in the global public health research programs. So what are some of the educational programs that we've been doing so far? Well, we've been doing global public health rounds, grand rounds now for 2 years. So this is about number 14. We have graduate and undergraduate coursework. I'll give you some more details about each of these later. There is the Global Public Health Study Abroad program. We have a Global Public Health Certificate, Global Health Certificate, graduate, kind of the equivalent of a minor if you're a graduate student. We work with the Global Health Scholars in the Honors College to help them get their requirements done to go on our study abroad and to get an advanced experience. And then we've had a number of publications and student posters that have been presented. Now the final of the 3 aspects has been referred to as service learning, learning experience, is the knowledge implementation. This is taking what we've now learned, what we've taught and applying it back to the community, letting them know that all of their input, all of their activities have not been just for our benefit, but truly come back to benefit the participant of the research, to go back to the community. This is where it's the discussion of capacity building. This is where involving the community in the decision-making process as to what are the appropriate questions to ask. What are their needs? What are their conditions that need to be addressed? That we can address from a scholarly, scientific way to advance our academic knowledge by involving students so that they learn how to do research to benefit the community. And here again, this is just a brief overview. We'll talk a little bit about the toilet facility that many of you have probably heard about. We have a Healthy Family Initiatives. It's being done through community health compounds. There have been WASH, which stands for Water, Sanitation, and Hygiene campaigns that have been accomplished. In Uganda, we've had projects that do clean burning cooking stoves. And in Peru, we have completed the WHO Global Scholar school-based survey in the communities. So, to speak specifically on what some of these program activities have been, let me give you some numbers. The concept of coursework. These are things done here at the university. We have one undergraduate course and 2 graduate courses here within the Office of Global Public Health. The undergraduate course, since its inception, has educated over 165 undergraduate students, and 344 individuals have come through the graduate program through our 2 courses in global health. We've had 30 individuals. That includes masters, PhD, and other programs that are standalone come through and receive their global health certificate. The Global Health Certificate requires accomplishing 10 hours of required coursework of a set of mandatory classes in the context of global health, and then about 6 to 10 additional hours of elective coursework on global health issues here within the University of Utah, and participation at one of our community-based sites. We've had the Global Health Grand Rounds going now, like I said, this is our 2nd year. We have the Global Health Partnerships. We have over 17 partners now across our various sites, both here in Utah and Ghana, India, China, Peru, Uganda, and Armenia. We've had our study abroad programs, and we've had, and I have it here, 153 students participate in the study abroad programs. That does not include students from the College of Nursing or the School of Medicine. And we estimate that's about 30 for a total of somewhere about 180 students that have gone on our study abroad programs. One of the largest study abroad programs here in the University of Utah. And then local partnerships. We want to remember that global health, that Utah is part of the globe. This is not international health, this is global health. Everything that we do should not only focus on what's happening there, but also what's happening here and how we can implement programs, learn from other places, bring it back home here, what we're doing here, taking over there. We have local partners here in the state of Utah, including Community Faces of Utah, Utah Navajo Health Systems, 4th Street Clinic, and we have rural public health placement programs within the division. Our sites, global partnerships, like I said, 17 partners between our sites, our local collaborators here in Utah, so opportunities to, once one meets the global health certificate requirements for coursework, one can do the community engaged portion here in the state of Utah, or abroad at one of the study abroad sites. So, with that being said, what we'd like to do is take our 6 main study abroad sites and use them as the instruments to describe how the Global Public Health Program operates, our research studies, the knowledge implementation, the knowledge production, reproduction, and implementation. So, Sharon Talboys is going to take 3 of the sites, and then I will take the other 3. So, Sharon, if you want to start with Armenia.
Okay, thank you, Scott. My name is Sharon Talboys. I work here at the division, and I'm a PhD student as well, and I'm the co-director for our India Study Abroad program. I'm going to talk first, though, about Armenia, which is one of our sites. Haripsime Wright, who's adjunct faculty here, leads a study abroad. And it's not just a study abroad. All these sites also include the partnership building. So she's actively engaged with partners in Armenia, which is a country that has experienced kind of a crumbling of its health infrastructure, and they're in a rebuilding phase. So this project, especially as they start to reach out to partners like the Ministry of Health in Armenia, World Vision, USAID, it's really very much of a policy-based site. We're really researching the health systems, and also the students that go on these trips, you know, they get that aspect of it, but they also work with local NGOs, and they've done some of the needs assessment activities and studies while they're there. Haripsime also does a significant amount of online training, pre-orientation before the students go on the trip. And this one's been running, I think, 3 years now? I think it's gone for 2 years. Okay, so that one's going. And we also have a site in Uganda. The academic partner there is an Islamic university. John Shavers is the trip director for this one. We don't have an active trip going this year to Uganda, but there's ongoing partnership activities to cultivate that academic partnership and get it to the point it needs to be so we can have stronger ongoing studies, research, that community engagement aspect in terms of translating the research and taking students and mentoring them through that process. Some of the projects they've done in the past are certainly based in service learning. John has done eyeglass drives, and they've worked on seeing if technologies like clean burning cook stoves and making the bricks to build them would work to address the air quality issues and the respiratory infections associated with those as a student project. And then we have an India project as well that we've had now for about 3 years. We've had 2 groups of students go so far. T.P. Singh, an alumni from this program, is from there and has gotten Dr. Alder over there to Chandigarh to start get this project rolling. So we've spent a significant amount of time really developing a strong partnership with let's see here, this doesn't work, the Postgraduate Institute of Medical Education and Research. They have a school of public health. This is a major research institute in northern India. It's a government school similar to the University of Utah. It's a state-sponsored, for India it's the central government sponsored university, and they do a lot of research. It's postgraduate. They have a medical school. There's an NGO called the Meher Baba Charitable Trust who reached out to us when they saw Dr. Alder presenting on the University of Utah while he was in Chandigarh. There are 9 rural villages that have chosen into being part of this. So they're villages that, through this local NGO that's community-based, who actually serves a much broader population, about 185 villages, when we first went to the villages and had these meetings, the thought was from MBCT that if we're really going to do this, if we're going to set up this process where we come and do community-based participatory research, we translate that knowledge into community activities that the community is a part of designing, that the villages need to choose into this with their own, and exercise their own agency to do so. So we spent a lot of time the first year, village meetings, you know, there were votes, you know, people raising their hands saying, yeah, we want to do this. So we feel pretty confident that these 9 villages really are bought in and active. And then, of course, the University Division of Public Health, University of Utah. So there's one of our, this is what a typical meeting would look like in a village. We'd go, we'd tell them who we are, everyone would introduce themselves, and we'd talk about what could we actually do together. And the biggest paradigm shift, and I think this was a big paradigm shift for the communities, was that we weren't coming with resources that are tangible. We weren't coming with money, funds, stuff, those, you know, hard resources. We were coming with ourselves and saying, this is what we can bring. But you know, the resources are going to come once we spend the time and invest that time in partnership development into building something that will be sustainable. So we did needs assessments. First step. First year we had 15 of our students in the field. We had a few of the public health students from PGI in the field, and we found the community really wanted to tackle water, to a lesser extent sanitation and hygiene. So we did lots of work around environmental health assessments. The way we figured out what to focus on before we even went and did these assessments was through those initial village meetings, doing nominal group process, you know, listing out all the priorities that the community had around their health and prioritizing. Where do we look? Where do we even start to assess? So we started out with environmental, mainly with water quality testing, health needs assessment, with the help from MBCT, and we assisted, and this isn't just study abroad, this is year-round activity where we would consult with them, help them with a demographic and health survey, and then they censused the entire 9 villages, 14,000 people, about just under 2,000 households with a face-to-face half-hour survey. So they were able to conduct that to feed into this knowledge production and figure out what's going on in the communities. Social assessment, we talked to young people. We talked to the people who weren't speaking up in the meetings. We talked to the people who traditionally wouldn't speak up at a public meeting, young people, young women, young men. And so we talked to them separately and found out that there were a lot of issues around improving the status of girls, being able to continue your education, delaying marriage just a little bit longer so they can achieve some of their goals in life, and also access to more health care related to women. Okay. So this is in the throes of a truly collaborative needs assessment. These are all our partners, Utah, the Trust, Village Leader. If you could see the rest of the picture, all our students and their students are standing around as we figure out where to go deploy in the village. Our students learn a lot. They learn research methods. They learn how to do surveys. They learn how to conduct interviews. They learn how to take water samples and process that information. One long-lasting thing that came out of the water quality study is we've trained them. They now have an incubator. They know how to process their own samples. The villages are actually trying to figure out a way to do ongoing household drinking water monitoring, and we can walk away. And then we know we've done our job because they can do it. And they know how to analyze this data, and they know what E. coli is, and they know how to read their test results. Okay. So next steps with this one. The WASH campaign, and Megan Arnold's here. Dr. Vanderslice is a PI on this. Megan Arnold has done a lot of work on this project. And I feel like this collaborative, because of the amount of investment we put in to the initial partnership building, when there wasn't a lot going on the ground, but there were a lot of meetings, a lot of talking, and a lot of getting our ducks in a row. And it turns out that among the 4 partners, our missions, even though we come from different entities, are aligned. For us, the community is our patient. For PGI, they have a commitment to research and care of the needy. For MBCT, they have a commitment to rural villages and the community. So those missions, really do align to where now, through the needs assessments, through some of the research, there was some epidemiologic research done to find out where water was contaminated, and it was in storage tanks overhead. But that campaign has turned into something where in each of those 9 villages, 2 young people have volunteered and gone through 14 days of training that our division here helped with the curriculum, and now we have long-lasting health promoters, WASH promoters in each of the 9 villages. So it's really exciting this summer when we took our second group of students to see them actually debut their health promotion skills and debut those presentations in the village. One great thing about that one is that, where is it going with that? Hang on a second. To see, this year we had 15 students go from the University of Utah. Last year from PGI, the Indian University, we had 2 of their students work with us. This year we had their students matched our students almost 1-to-1. And their faculty outnumbered our faculty in the field. At the end of our almost month-long field activities, we were able to give out a certificate of participation between the NGOs, staff, our students, their students, and faculty, that there were 52 people that participated in the field activities, in that research, in that knowledge production, in that community engaged process. And you couldn't just get a certificate by showing up for a day. They were there consistently. So we felt that was a great success. We also had the opportunity to evaluate 15 Anganwari centers, and to put it in U.S. terms, it's similar to a Head Start program. So each village, it's a daycare, lay daycare, it's nutrition services, it's linking kids to care, and you're working with that preschool age group. So we did a health system study with 15 of those centers, and we also did a women's empowerment study, basically looking at this gender equity issue, where certainly there's a lot of gender issues, domestic violence, education, problems related to dowry, girls who aren't achieving what they want to, girls who feel oppressed. However, to go to these villages, we haven't known them for a long time. Education for us, for the partners, and for the villages was something that we could talk about. It was a winnable battle in the broad scope of gender disparities. So we focused on gender education, or why are girls dropping out after primary level schooling, and what are the consequences of that, and getting their life stories. So we actually did focus groups, and we did 47 in-depth interviews this summer. So we have a lot of great work done by our students and the Indian group and our partners locally. So this is a sampling of the kind of experience I have, and I bet you can imagine, to have our students, really hearing those stories and really going through those interviews and really getting a deeper understanding. And it's through all these activities that our learning objectives for our students are met, are they becoming global citizens? Are they learning research methods? Are they figuring out how to apply this to their careers? And those are things that we want to have happen through these programs. And now I'm going to turn it over to Scott, who's going to wrap up with the other sites.
All right, thank you, Sharon. So let me point out a couple of things that I passed over quickly. There are a number of common threads that you'll see between their 6 sites. One, all of our programs are faculty-led study abroad programs, meaning that there's a faculty member here within the Division of Public Health that guides each of the programs. It helps to make sure that the students have a good and excellent educational opportunity, and that we build our relationships with our partners at our collaborators institution. The second thing is, these are community engaged. So the community has a say in what the research is. These are not our projects imposed on others, but they're what the community comes up with. So while the communities, some of them may be common, water, sanitation, hygiene, malnutrition, the community decides what their priorities are, and they get a say in the decision-making process as to what the research areas of interest are. And that will become relevant here in a minute. In China, this is one of our programs that's been going on for 2 years. Last year there were some health issues that prevented our program from going. But the first year that they went, they had a very successful program. And they were very interested in having them come back. And we're continuing our program in China. Now what they did is we have a partnership through the Global Health Initiative here at the university with the Medical College of Hainan in Hainan, China, kind of on the south coast of China. And we've had exchanges between medical students and back and forth. So we've had the opportunity now to have public health faculty and students exchange as well with the Hainan Medical College. Our first group was a very small group of about 4 students and 1 faculty member. And they went over to do that initial relationship building and needs assessment. So the project, they took on a single project their first time, which was a childhood malnutrition study. And they went out in the community, partnered with students and faculty from Hainan Medical College, conducted a health survey, again, much like the idea of the Head Start centers here in the state of Utah, but the Hainan version. Now, I will say I cannot talk about the results right now because they're currently being prepared for publication. But the Hainan experience is one of those where now Hainan Medical College is coming back and saying, this is the information. Our community now has taken that malnutrition information, and this is what they want to look at next. And so the community has invited the representatives from the medical college and from our university back to continue to answer the questions of what's causing and how can they remedy malnutrition in the kids in the community. Our youngest program is the Peruvian program. It only started, really, our first visit to Peru as the Division of Public Health was last year. We've been working in Trujillo, which is here kind of on the north coast, second largest city in the country of Trujillo. And we've been fortunate to partner with a university called the University of Cesar Vallejo. Cesar Vallejo was a Peruvian poet who received a Nobel Prize for his work in literature. The University of Utah has had a presence in Peru for a number of years. However, that presence had never found a good collaborative partner. And then a couple of years ago, they identified the University of Cesar Vallejo. At the University of Cesar Vallejo, they have a medical school, but they don't have a public health program. Now, and I mean no disrespect, but this gentleman that looks like he's as tall as the rest of us but is standing on 2 feet of stairs is known as the engineer. He's a gentleman that was a very successful Peruvian businessman. He's now the mayor of Trujillo. He's the one that donated the money to establish and to build the University of Cesar Vallejo with 7 campuses across the nation of Peru. He's the benefactor of the university. His interest is in building community centers where the university can have outreach, because he believes that the education of the student should not be just for the benefit of the student, but that a student's education should actually be taken back to the community and benefit the community from which the student derived. So he's given the money to build community centers. The law school goes out and they have law clinics. The medical school goes out and they have medical clinics. The sociology students go out and tutor. So we've been able to take the opportunity to use these clinics and the community health workers in these communities to go out and to meet with the communities and to identify their problems or their concerns. Our first introduction to these communities was by using a well-designed tool by the WHO called the Global School-Based Student Health Survey. This was a 72-question survey that was given to students between the ages of 11 and 16. In 2010, when the WHO did this around the world, Peru was one of the representative countries, and there were 2,700 surveys done across the entire nation of Peru. So we went back to our little community in Trujillo, selected 5 secondary schools that would include kids of this age, and we did 2,700 surveys within this community to equal what had been done in the entire nation of Peru previously. The results of those surveys showed that 63% of the students began drinking alcohol before age 14. 25% drank daily. 20% felt that it interfered with their educational activities. 33% got their alcohol from their friends. Other questions touched on drug use, sexual activity, physical abuse and bullying, educational resources, and malnutrition and hunger. So in Peru, we found a partner of the School of Medicine at the university who they don't have the public health program. The students are required to do a community engaged project, and so it's given the students the opportunity to go out and to engage with the community at their community health centers and to become involved in taking the information back to their community. And then we always swing by Machu Picchu for a quick, sunrise, walk through the Inca Valley, visitation with the Inca gods. The last one, though, that I wanted to touch on was Ghana, because this was really our first program. It's the program that has matured the most. It's the program that's grown up, that's been our model and our success from which we've keyed off to build our other programs. If you look at our partners in Ghana, we've really gone beyond just university to university. It now includes the University of Utah, the Kwame Nkrumah University of Science and Technologies. Within that university, we've partnered with the School of Medical Sciences, the Department of Engineering, the Department of Agriculture, and now we're starting to look at the planning, community planning within the university. We work with the Barakesi District Assembly. That's the government. That's kind of like the county commission for this area of the country. We work with the health district. We're working with the district education officials. We've got the traditional chieftain and the Ashanti Bantama regional leadership from the traditional non-governmental side. And then all the way up, we've got support from the National Ministry of Health within Ghana. We started out in this small community of about 20,000 individuals with the goal to expand to the entire district and then take the positive projects nationwide. A brief summary of some of the projects that we've done in the Ghana in the BCCDP, the Barakuma Collaborative Community Development Project, over the past years include looking at childhood malaria and schistosomiasis. We now know that there's somewhere between a 30 to 50% asymptomatic carriage of the malaria parasites in kids under the age of 5. What's not known is, do you treat them? We're working on that one. We have identified almost 20,000 individuals in this community by household, by name, and everyone now has a GPS address of their house. So we can go back to that individual and say, 3 years ago you were pregnant. How's your baby doing? We can identify by name and household the individuals that were willing to participate in our projects. We did verbal autopsies, going back and saying, so what's changed since the last time we visited? What's gotten better? What's gotten worse? To continue to improve our database on the socioeconomic and health status of our community. And then just in the past year, one of the projects that arose out of the community was a concern brought by the hospital. So in Ghana, up until a few years ago, pesticides were regulated. And not everybody could go down to Home Depot and buy a gallon of diazinon and take it home with them. Well, I don't know if you remember, but 30 or so years ago, there was a lot of talk about how you store poisons in your house, and you shouldn't put them in empty Coke bottles and keep them under the kitchen sink. And so we kind of have learned that you don't store the rat killer next to, the M&Ms. Well, with pesticides only recently being deregulated in Ghana, this concept and this education had not happened yet. And the hospital that serves this area was seeing an increase in the number of poisonings, accidental and intentional, due to the improper storage of pesticides, herbicides in the house. They think, but nobody had any numbers. So this past summer, students from Ghana and students from the University of Utah got together and organized and did a community household survey of pesticides, where they were stored, and an educational component of how should they be stored, what's safe storage of pesticides. And then we'll watch over the next few years readdressing this and see if we've been able to make an improvement in decreasing intoxications from pesticides that are stored in the community. Now, some of these, like I've listed above, are a lot of just knowledge gaining. Saving, you can prevent some toxicity, get a lot of information, but there have also been physical projects that have been accomplished. The construction of schools. We have an economic development program going on where there's an agricultural community that's now a co-op that's growing oranges and selling corn. The co-op is raising money and paying back the loans that they got to buy this land. The university in Ghana is using this as a model for how to develop other cooperatives throughout the country. We've looked at health systems issues. We've been developing a series of integrated family health using community health posts, CHIP compounds, C-H-I-P, CHIP compounds in the community, where there are community health workers who are stationed that can recognize based on the integrated management of childhood illnesses. And they can appropriately recognize, diagnose, and treat certain conditions that are popular in the community and then advance the individual up the healthcare chain as needed, getting the appropriate care at the appropriate time to improve the health in the community. We now have 3 CHIP compounds that have been constructed and that are up and running in the Barakesi subdistrict. Another project that derived from our Ghanaian counterparts was an adult health screening, looking at the prevalence of diabetes and hypertension in our adults in the community. The adults have felt a little bit left out because a lot of the programs focus on kids, because it's childhood integrated management of disease. So the adults wanted to know what was going on. Those results are being reviewed for submission for a presentation this week. The first few years we did this, we took the information, we brought it home, we published it, and we thought we were doing a great job. About 3 years ago, the community said, well, where's the information? And it's hard to tell somebody out in the middle of Barakuma that doesn't have electricity or running water, well, that it's published in the West African Journal of Medicine, or that it was presented at the Global Health Education Conference. So what we've started now, each of our study abroad programs has a specific group that goes back and reports to the community what their participation has been able to advance the knowledge of global health and what it will benefit their community. So all of the results are now reported back to our community participants in our local communities. So no longer is it really just us learning things to share over here, but it's being taken back and given back to the Ghanaians. Now, what I'd like to do is finish with one example of how the community approach really changed the way that we have approached global public health. And that is one of the stories from Ghana. And I apologize to those of you that have heard this before. I was able to go to Ghana the first time as a medical student in about 2002. I went over because I was interested in global health. I had a background in water. So as a medical student, I went over and I did water quality in a number of hospitals and clinics and found some of them were contaminated and some of them weren't. Interesting enough, I came back to medical school here at the university, thought that my experience was probably complete in Ghana. Well, the next year is when Steve Alder started going over to Ghana and looking at developing a global public health program in Ghana. One of the concerns in the village was water and sanitation. Because of my experience, they said, hey, do you want to come back? So a couple of years later, I was invited to go back to Ghana to work on water and sanitation. And I thought, well, everybody wants clean drinking water, so obviously we're going to do drinking water. So I went over and sat down with the community leaders and said, how can we fix your drinking water? And they said, good for you. But you know what? We have bilharzia. We have schistosomiasis, a parasite from peeing in the water and playing in the water that you just peed in. We'd rather get rid of our bilharzia and address the sanitation at the elementary school and worry about our drinking water later. So we had to change our approach, and instead of coming in with drinking water, address sanitation first. Now, the reason they were concerned about sanitation, this was the pond where everybody did their laundry and the kids went swimming and everybody got schistosomiasis. And this is the toilet, the bathroom, the pit outside the school. It's about 30 feet away from the windowless building at the elementary school. Now, when you're a kid, when you're 5, 6, you can go out, you stand on the 2x4, spread your legs, and take care of business. Really don't think much about it. The problem is the flies go down and they pick up the poo and they fly across and they land on the kid and the kid gets sick. The second issue was by the time the girls started hitting about 10 years old, they started recognizing that there was a difference between girls and boys. And while the little boys could go out and just turn their back to the school and take care of business, the little girls couldn't do that. So the little girls started going home to go to the bathroom. Now this is a subsistence farming village. So when the little girls went home, neither mom nor dad were there to prompt them to go back to school. So the lack of a toilet facility was one of the reasons that the young girl's education was stopping about the age of 10 or 11. So we sat down with the community and they said, we want a toilet. So we worked with the university, with the engineers. We just took concepts from right here in rural Utah on how do you design and build an appropriately set on-site wastewater treatment facility. We developed a program in conjunction with the KNUST and Department of Engineering to test their soil, to measure how you build a toilet. And then we, the community, built a 10-seater, 4-sink, no waiting, gravity-fed, running water, flush toilet. Now, just a word about the construction. This was kind of, yeah, I like building toilets. You know, I mean, everybody needs a place to poo. And one day I showed up. The community had dug their 250 feet of trench, 6 feet deep. And I arrived with 5 cubic yards of gravel to backfill, to fill in the bottom of that trench, to put in the perforated pipe. The problem was the truck arrived an hour before I did. And when the truck arrived, the community was there. When I arrived, the community had gone home because I was late. I had 5 cubic yards of gravel to put in 250 feet of trench and nobody to help me. So I picked up the shovel and I thought, well, might as well start. And I started shovelful by shovelful putting that gravel in the trench. Within 20 minutes, we had 75 community members, the majority of which were women, and they would take these buckets, 5-gallon basins basically, pick up 60 pounds of gravel, put it on their head, walk across a 2x8 down my 250 feet of serpentine trench, and within 45 minutes they backfilled the entire trench. This really wasn't my toilet facility. This was their toilet facility. This is what they asked for. We did it in a way to involve the University of Science and Technology in a way that the community members have learned how to build, how to site, how to construct their own wastewater treatment on site. The engineering students now know how to measure the soil, to put new toilets in, and the community, hopefully, the kids stay in school now. So what is our mission as Global Public Health, the Office of Global Public Health? It's really the advancement of scholarship. Now, I break this down in 3 areas. We work faculty to faculty, scholar to scholar, academic to academic, to gain new knowledge. That new knowledge, we work with our students to expand that knowledge, to teach more people. That's the knowledge reproduction. And then the knowledge implementation, we do it in a way that involves the community so that they get the benefit of our learning and of our teaching in a way that the community solves their problems at the same time. So what does that all mean? It's really just a different approach to making a difference.